Going farther back, I feel like there's usually another row. Like crazy.
I guess I'll share screen too because I'll be showing it there. Okay. I can even. Okay.
It doesn't really change. It just means. Everything that you all know. I just doctor know like usually like times I haven't worked with no. Oh, okay. I was just gonna reserve.
Oh, you mean
A few days. Oh, Monday. Sorry.
As people roll in, keep going.
Yeah, it's your show.
Okay, I think there's some people on Zoom. Looks like there's people there, so I guess we'll get started. So for this session, I thought we can focus on some GI liver unknowns. Some of these cases, actually, no, these cases are the cases I've encountered during residency, and we got a slide scanner, so I was able to scan some slides, and that's where they come from. So I don't have any disclosures. I'm very sad. I'd like to have some disclosures one day. The learning objectives is there's 8 cases. We may not be able to get through all 8. We might get through 4 or 5, and then whatever's left over, I'll try to finish it off at like 5 p.m. in a week or so. You know, it just exposure some of these cases, do some active learning, look at some bread and butter cases and some maybe harder cases. Look at I included multiple choice answers in the prompts that I sent you guys to kind of help you, so we can work through how to eliminate the answers that it's not, because like some of you guys have boards coming up, so it could be useful. And then I guess, yeah, because like on your boards, like if you have a question, you have like 5 multiple answers, you know, if you can narrow it down to 2, you go from 20% correct guess to 50-50 correct, which is a really good odds. So it's kind of to do that. So let's talk a little bit about normal histology of the liver first before we dive into the cases. Liver is a really big organ, and it's okay, here's my mouse. It's supplied, it has 2 I guess blood flows that are supplying it. It has 70% of the blood comes to the portal vein, 30% comes to the hepatic artery, and everything leaves via the central vein. That's what it looks like. And then if you look at the microscopic kind of anatomy, you get this octagon or hexagon, or I think it's octagon. It's think it's 8, 1, 2, 3, 4, it's 6, it's hexagon shape. That looks kind of like a portal, and in the center of the portal, you have the central vein, and then on the periphery, you have the artery and the portal vein. So the blood comes in through here, it gets filtered through all the sinusoids and the hepatocytes, and it goes out into the central circulation back to the heart. Bile, on the other hand, goes the other way. It starts getting synthesized here, and it leaves through here. So that's kind of like, there's like opposite flows. On histology, you see more like, that's what it kind of looks like, the hexagon right here. So, there's the portal, each portal tract is composed of at least one artery, a bile duct, and a portal vein. So this is what it should look like. There's different gradients of perfusion among the liver. So in the portal zone areas, like around over here, you have the most amount of oxygen. But then as the blood flows here, you have the least amount of oxygen. So like that way, if you have ischemic injury, it'll be more prominent maybe over here versus than here. So these hepatocytes will start dying first. And that's kind of where the zones come from, like 1, 2, and 3. 3 is pericentral vein, and 1 is periportal vein. And then we have different special stains like reticulin, which highlights type 3 and 1 collagen, but I don't really want to get into this part too much. Just mostly focus on the H and E. So, okay, this is the first case. It's a 36-year-old female with a liver mass. You guys don't have to come up and drive these. I can drive them, but if anyone volunteers and wants to kind of give it a shot, you're more than welcome. But again, you don't have to. So, does anyone want to give a shot at describing this, like histology? Again,
I mean, I didn't look at them, but
it's cool. It's just more like
from here it
yeah.
looks pretty nodular.
Right. So it's pretty nodular. There's this big nodule here. There's some more little nodules here. Do you have like what are your thoughts? Like what are you going for, like malignant? Are you going for like?
I mean, for now,
Yeah.
not
Right.
malignancy.
Cool. Okay, I guess I'll zoom in and look around. Do you have any areas that you want to zoom in around, or?
I guess we can do it on the bigger nodule,
Okay.
just to check it out, and then we can move to the.
Sure, that sounds good. So, I mean, the way I was trained on looking at liver from some of our attendings during residencies, they said that when you're looking at liver, see if you can see any normal histology. And if you don't see normal histology, that's when you start wondering, is this something else? So far, like, has anyone seen a portal tract yet? Right, yeah, there's no portal tracts. There's like some maybe a little macrovesicular steatosis here. There's something here that may look like an artery. Maybe, right? I don't know. It's hard to say. Maybe some sort of venous structure, maybe. But so far we don't see bile ducts, right? We don't see like a portal tract anywhere. There's some inflammation on the periphery of this nodule. And then we go into this like kind of nodular area. So, hypothetically, if you were to biopsy this, you could be like, maybe this is cirrhosis, right? You would go get a trichrome and you'd be concerned for that. But here you're kind of looking around, and what do you guys think these thick muscular things are right here? Yeah, totally. So you have like a lot of unpaired arteries. What kind of things do you want to have at the top of your differential if you have unpaired arteries? Yeah. Somebody said FNH, maybe adenoma, right? Are you concerned for like a malignant hepatocellular lesion like HCC? Right. But like if you're looking at these sinusoids, would you say like how many plates thick do they look like to you? Like 2 or 3. Yeah, like what about this guy right here? About 1. Yeah, about 1. So that's kind of, I think it's not fair to give just an H&E of this case, because you need immunos to work it up. But just looking at
Really?
this,
You need me to look at that? Really? Do you?
I
That'd
mean,
be nice.
if we, if you,
Let me have a question. What do you get for the pathology before you do the imaging?
yeah, so the differential here, we have like lymphocytic kind of aggregation, we have nodular architecture, we have a lot of large unpaired arteries. So things I was hoping you guys would think about would be like adenoma or FNH. Maybe cirrhosis, but I gave you, I don't think I'm not sure if I gave you that option. But if I did, that was just, huh?
Was the patient?
Oh, and you also, you also got a case history of like a female with a liver mass. So more pushing in the neoplastic nodular differential versus like a drinker with cirrhotic or something like that. So hopefully like that was what you guys were thinking. If you were, that's great. I'm just pull up the PowerPoint and go over some pertinent features. So grossly, like what you would expect to see is a nice kind of central scar. You guys didn't get a gross picture, but hypothetically, you would see that. From these are from Expert Path, so thank you, Expert Path. But we saw some nodular architecture. We saw some kind of like unpaired arteries with maybe some lymphocytic inflammation on the side. And not super specific findings, but again, more unpaired arteries and more.
Yeah, I think also the size of the arteries, so typically an FNH, that central scar, see very large caliber arteries. I typically reserve the word unpaired artery for the smaller arterioles, which you can see in both, right? But these big, large vascular channels, which you see in the central scar, are more typical of FNH.
And then, so here's more kind of big arteries. So differential is HCC, well diff, moderately diff. Probably not this because we didn't see any like thick intrabeculate or atypia. So adenoma and its subtypes and FNH. And this I just threw it in just to confuse you guys. So we hypothetically, if we had immunostains, we could rule some of these things out. We'll talk about more about these, like HCC should stain for diffusely for glutamine synthetase, positive for glypican-3, HSP70 and PCA, and you should also have a high serum CEA as well, which is a liver marker. Not always, but it should be there. Adenomas and its subtypes, we would need immunos, and FNH also helps with immunos. And then question said it's a mass. So this one you can rule out pretty quickly. So if you were to get this hypothetically on a board exam, you could rule out cirrhosis quickly, you could rule out cancer quickly, and then you'd be stuck with a 50-50. So that's kind of helpful. Yeah.
Would you order AFP as well? For HCC? For Dr. Nasser?
I don't know. We didn't do it in this case. So I don't.
So alpha protein is a good marker for HCC, but it's not very sensitive. The sensitivity is under 10%. So most of us have discarded it. The marker that we most commonly use, the one we have, is glypican-3. There's a number of other markers, as you have said, HSP70 among others. I've never had any experience with them. Glypican-3 is one that is more universally used. If you're desperate, you could use alpha protein.
Yeah. So the things I want to talk about is hepatocellular carcinoma. Here, you'd want to see like thick intrabecular plates that are very thick, very, very obviously thick too. Reticulin would show that these plates are much larger than 2 to 3 cells thick. And CD34, like I don't think we use that routinely, but it shows like sinusoidal capillarization, and literature says that can happen when these cells become damaged and reactive and sinusoids become more capillarized. But we wouldn't use this so much. And then glypican-3 it supports malignancy, but again, it's not super specific. And like you said, AFP, it could be possible. So histologic grade, these are differentiated based on well, moderately, and poorly. So this is from the CAP. I was trying to find a literature or some sort of source that would say like criteria for differentiation, like how much is well, like what do you need to call moderate, what do you need to call severe. There's really no criteria, and it's one
No,
of
I
the.
can tell you my gestalt, right? So if I'm
Yeah.
having a really hard time distinguishing between an adenoma and a carcinoma, I call it grade 1. So I'm sort of really struggling, I'm unsure, I'm ready to write a long note, that's grade 1. If I'm hard pressed to identify it as liver, so it's not looking obviously like liver, that's grade 3. If it's impossible to tell what tumor it is, then it's undifferentiated. Everything else is moderately differentiated.
You know what I mean.
And I also have pictures. So this is well
See,
differentiated.
that would be well differentiated. I'd struggle to call that HCC, right? On the right, that's clearly liver, right? Because the cells look like hepatocytes. But it's not grade 3, so
And
now
then,
you know my secret.
and then this is more grade 3. You'll see like
Yeah.
mites, more atypia. Yeah.
Now I'm having a hard time defining it as liver. I mean, wondering, could it be just some adenocarcinoma?
Okay, and then, okay, so again, these are all from Kurt's notes. Kurt's notes, shout out to Kurt's notes. I passed my boards because of Kurt's notes. So again, hepatocellular adenoma, there's 4 types: inflammatory, beta-catenin, HNF, and there's supposed to be a 4th one, but I don't see it here. That's okay. But really, for hepatocellular adenoma, for your boards and also for practice, you want to know how to differentiate these two. The worst one is beta-catenin because these go on to become neoplastic. There's a risk for these to become neoplastic. So you want to rule that one out and you'll get a beta-catenin. If it's nuclear, that's positive. If it's cytoplasmic or membranous, it's negative. Here we do serum amyloid A, and for us, CRP is a send out. So if this is positive, it's more likely to be inflammatory. But also, here's there's a caveat here. I think 10% of inflammatory can be beta-catenin activated. We had a consult that was both, but it's not common, very, very rare. And then HNF1 inactivated, it's loss of LFA BP. So yeah. And I think that's it. FNH, we talked about it briefly. So central scar, it's due to like a regenerative response of hepatocytes. It's pretty common. I think it's associated with OCPs, but then some people say it is, and some people say it's not. So I don't really believe in it too much. The glutamine synthetase is pretty high yield. If you get like zone 3 staining, that's wild type. If you get diffuse map-like staining, that's positive. And yeah, we talked about this. This is just pertinent features. This is what I wanted to show you because this is something that confused me in residency so much. I never got it until like my boards. This is normal staining. This is just like zone 3 central vein staining glutamine synthetase. And then map-like staining is just like diffuse, disorganized. And this paper says that that's because zone 3, these hepatocytes that live here, they make glutamine synthetase. So like, wow. In this case was signed out as, there's also a really big cavernous hemangioma here, but we signed out this case as like FNH, and we did map-like staining by glutamine synthetase, and we showed that reticulin retained normal architecture. So that.
Vikram, would you comment on the radiological appearance of these lesions? Just because I have an anecdotal thing to say after that.
Yeah, these radiologists are pretty good at making these distinctions. So not only can they see the star, but they also have these radionuclide tracers now, where they can tell between F and H, and they can tell between the various adenoma types. And so they've gotten pretty good at this business. Almost putting us.
I told about it almost 20 years ago. You remember? I was diagnosed with angiosarcoma of the liver.
No.
Yeah.
Probably not angiosarcoma.
I would not be talking to you if it was the right diagnosis. This diagnosis was made, let's say, in the lung area, or maybe a little wider. I don't want to. So, FNH can be extremely confusing that way.
Oh, it's called radiology.
Radiology, yeah.
Yeah, no, they got
No.
much better.
Yeah, okay, they got it much better, correct. But, it's a really vascular lesion.
Yeah.
So it's either MRI or, whatever measures the vascular tracers and so forth. It makes it look like, things like a bad hepatocellular carcinoma or angiosarcoma. And I didn't have a biopsy. I went to surgery at Mass General, and the frozen section diagnosis was FNH. It gives me back my life, but
Wow.
I was surprised that, I showed these images, MRI images to guys here around that, my senior people, they all put the figure to angiosarc.
I've seen that.
You didn't do the frozen, it was a colleague of yours,
20 years ago?
almost 20 years ago.
I was a young attendant. People give me
It was a well-known gastroenterologist because
Was he
actually,
French?
huh? Because Harvey called the guys and then said, I got one of my faculty is having surgery. I want such and such to take a look at it for the section. That man, we learned a lot. You didn't have the privilege of interacting with him. He was a great teacher. Oh yeah.
Well, he's looking down at us even now.
Exactly. I'm sorry for.
No, it's okay.
Anecdotal.
Anyways, thank you for the interesting story. The teaching, so for this case, the teaching objective was like, do you know FNH well enough to differentiate from its close mimickers, and then why do we care? And it's a bread and butter. And also going forward for your boards, like normally, like the way they build those questions, from my experience, is like they'll write it to test one fact for each thing when you're doing those Q banks, and then they'll just throw in 3 or 4 other answer choices that make no sense or kind of make sense, so that when they explain you the answer choices, they just focus on that one entity and they ignore the rest. And very frustrating. But that's how they try to test just one thing with these questions. So for this one, it was like, do you know FNH well enough? We don't really care about the other entities, kind of thing. Okay, so this case, it's hard. This is a hard case. This is a super hard case. And it's I just wanted to show this case to you guys because it's rare, so that you're aware that this exists. So it's a 65-year-old female. She's got no history of liver disease. She's got a lot of other history that's not super relevant. But then she had the jaundice, painless jaundice, so that's relevant for us. She got COVID vaccine a few weeks back, and then she got a booster, but then she can't remember if her symptoms were before or after. She doesn't use any herbal supplements. For us, that's important because that rules something out. And then CT showed no biliary dilatation, MRCP was unremarkable, and then they got labs. And during COVID, I think there was a case report or some case series about people who got like the COVID vaccine, and then they got like hepatitis relative to related to the vaccination, but was more like a reactive kind of thing. There was some papers floating around about that and abstracts and stuff. So I kind of gave away the answer to you guys right here, because these two antibodies, like when you see them, especially on your boards, it should just be like muscle memory. You just pick the answer, you don't think twice about it. But antimitochondrial, it's PBC, smooth muscle, it's AIH. When you're seeing these two, especially in your chemistry sections, like that's all you need. These kind of don't matter anymore because we have the antibodies, but we'll look at them briefly anyways. Her AST and ALT are elevated, so that's a hepatocyte damage marker. ALK phos is elevated, so that's a biliary damage marker, and her bilirubin is elevated. So like her liver is getting damaged, right? And then just from this so far, without even looking at histology, we can already have a differential. Is this like AIH? Sorry, is this AIH, PBC, AIH overlap? Or is this acute hepatitis, like hyperinflammation due to the COVID vaccine or COVID booster? Like that's a possibility. But our differential here, like at the moment, is sorry, just trying to find my mouse.
There's one more possibility,
Oh.
that's called cholangiopathy. So there's a form of cholangiopathy that is supposed to be related to COVID. These are typically patients that have been very sick. It's unclear whether it's really COVID related or it's just from the
the bad COVID, when they were hospitalized and there was ischemic injury to the bile ducts, among other things. These are people typically who have been ventilated for a long time. But this seems to be immediately, what's the duration between COVID and the symptoms?
I remember it was a couple of weeks.
Couple of weeks, so that's
Yeah.
not enough time. I've heard of this COVID vaccination related hepatitis.
Yeah.
I think it's a very dubious entity.
Yeah, I don't know. I'm just a fellow, so I don't.
No,
I don't have.
I'm
an
talking about
opinion.
market because, it's a very controversial topic came up. People were afraid to sort of start talking about it.
Yeah. So I gave you guys here, let's see. Let's go full screen. A liver core trichrome, which is kind of cool to look at, but we don't really need it too much. I mean, it just shows us that there's not as much fibrosis going on and here. But I just want to focus because we're already like at 25 minutes. I just want to focus on here. So, okay. What do you guys think this area is? Or what do you think it should be? Portal tract, right? Right, but it's really busy, right? Like even from low power, you're looking at this and you're like, wow, this is so blue. And it's so inflamed. So you're looking here, you see a portal tract. So what are these guys right here? Yeah, we got one bile duct. We got another one, right? Maybe one more. When these lymphocytes and like inflammation and there's plasma cells in here too, like I'll prove it to you. We'll zoom in. I'll show you. When they're spilling out from the portal tract into the parenchyma, like what do you guys call that? Interface, yeah. And when you're saying interface hepatitis, like what things are you thinking about? Yeah, autoimmune is should be definitely up there. So you're already kind of like seeing, like you see this bile duct, it's like a donut, but half of it's been eaten. So that's bile duct damage. And then we have like maybe some plasma cells. It's kind of hard to see on here, but there's maybe one here. There's areas where you could see them a lot better. There's a bile duct here that's kind of being damaged. An artery that's hard to see, and then another bile duct here that's kind of being damaged as well. So you already have bile duct damage, you have interface hepatitis, you have plasma cells. What are these guys right here?
You gotta zoom in.
What's that?
Can you go higher power?
Yeah, sure. It used to be a hepatocyte. I'll give you a clue.
That's balloon degeneration.
Yeah, it's close. It's close. It's like either the apoptotic hepatocyte or Councilman bodies. So it's just a dying hepatocyte. It just tells you like that there's hepatocyte damage. You have like some lobular inflammation as well going on here. Moving forward, as you go from portal tract to portal tract, you're seeing more and more of the same kind of
And the
picture.
patient doesn't have any history of hepatitis B or.
No, nothing. She just presented with like jaundice and belly pain, and they did a serology on her and they found those two antibodies. And this was a rush biopsy over the weekend. With that, I was very unlucky to be on call for that weekend. So like that was my biopsy. So yeah, you can see a plasma cell here, another maybe plasma cell there, something dying here. So generally, like what you guys are saying, like you're kind of you're on the right track. Like when you're seeing this and plus those antibodies, you should be concerned for some sort of autoimmune histology. And then because we're seeing like biliary duct damage as well, and more like some cholestatic kind of damage, and also and because of the antibodies, you're thinking about maybe an overlap syndrome. And that's not rare, and there's kind of more to it than I'll show you what I mean. There's more to it than kind of just that. So, okay, let's go through the pertinent histology features. We had lymphocytic plasma portal tract inflammation. Here's like this, maybe like an interface area that's with the inflammation spilling out. We got bile duct damage over here. We got acute hepatitis, which is just lymphocytes infiltrating lobules. And we got some necrotic hepatocytes here as well. Here's more like bile duct damage. There's plasma cells. There's proof they're there. More bile duct damage. So kind of more the same thing over and over again. So we're suspicious for autoimmune hepatitis. That's, you know, interface hepatitis, which is the hallmark lesion of active autoimmune hepatitis, is what you would expect to see, and it's generally zone 1 hepatocytes. So that's all. There's more text here, but I kind of want to move in the interest of time. So what we have so far is we have it's a lady. It's an acute process. We have lymphoplasmacytic inflammation with interface activity, smooth muscle antibody, and high IgG. So that favors AIH. We also have PBC findings. We have biliary damage. We got lymphocytic cholangitis, which just means like lymphocytes are attacking the bile ducts. And that's called lymphocytic cholangitis. That raises PBC to the differential. We have, mitochondrial antibody as well, and more like a biliary process going on. So with this case, and it's more like there's a primary process of maybe AIH and maybe a secondary process of PBC. At least that's what we were thinking. This was signed out with a thesis. This is a really long note, but let's not read it. You know, we pretty much told them it was overlap, suspicious of overlap. And then we listed the features here. There was also some immunos and stuff that was done. And then this attending was super duper nice because she was helping the clinicians with this case. It's such a rare case. She was saying that, hey, listen, you know, in this overlap syndrome, you need like 2 of the 3 features. So ALT elevation greater than 5 times normal, which I think we were close, IgG elevation ×2, and a positive antibody, and moderate to severe activity. So like, you know, what happens? So you sign up this case, you're like, great, we're done. That's great. And I'll get to like why this criteria is important for clinicians. So there's, for your boards, again, a high yield tidbit. There's 2 types of autoimmune hepatitis. There's adult one and a pediatric one, and they might test you by trying to give you the antibodies, and they'll put that in a question stem. And if it's like LKM, which is like liver, kidney, microsomal, that's like pediatric autoimmune hepatitis. If it's ANA, a smooth muscle, more like adult. But again, like this is just an idea of like, so you guys know what exists. Okay, a lot going on here, but luckily we don't have to do this. This is, I think the clinicians have to do this. They have to take these biopsies and then they take the patient's overall features and then they use a scoring system to diagnose autoimmune hepatitis. So you can see like gender plays a role. If they don't drink, they get 2 points. If they drink, it's probably alcoholic hepatitis. Whether they use hepatotoxic drugs, autoimmune diseases, immunoglobulin ratio, antibodies, ANA, hepatitic markers, treatment response. You know, if they give them corticosteroids, does it treat it? And that makes it more likely that it's probably AIH, histology, and then, you know, they do an aggregate score. I'm just putting this here so that you guys know that it exists, that's how it could be done. Okay, case number 3. This is, we're doing good. We're at 33 minutes, you know, so timing wise, we're moving along. So we're at case 3. So this was a 39-year-old female with a small intestine mass near ileum. So this was when I was on AP call, and we got a call on a Saturday. It was afternoon. Thank God it was a night.
Same Saturday?
No. It was like later. I think it was my end of second year, maybe early third year. And it was a Saturday afternoon, and a surgeon, we were like, you have a frozen coming out, so come to the frozen kind of room. So we go to the frozen room, and then we get this, you know, specimen, and the attending surgeon, it was actually like a trauma general surgeon who sent this. And he was like, yeah, this patient presented with like acute appendicitis, but then I was looking for the appendix and the appendix wasn't there. And instead we got this nodule and we're just not sure what this is. So it's just kind of, you know, not sure. So the way we signed this out as a frozen, we just called it a spindle cell lesion with low-grade features pending permanent sections. Then we had to call another attending and show him through the eyepiece like what it was as well, because it was really weird. We did not expect to see this case. Like this is one of those cool, weird cases. Sorry, I'm looking for the mouse. Okay, there we go. So this is kind of like the GI / bone and soft tissue crossover. So this was the mass. You know, anybody wanna, like, when you're looking at this right away, is this like malignant appearing or more bland appearing? Like, just from this histology.
It's in liver, architecture seems destroyed.
No, it's not liver, it's not liver.
He's tricking you.
It's not liver, it's like
Mass in
around
the
the
abdomen.
appendix area.
I'm sorry, okay.
No, but like when you're looking at this, does this like make you think it's malignant or?
Kind of
Yeah,
malignant,
I'm
right?
not sure from here, but is that desmoplastic changes? I mean, I kind of
Right.
see the trauma, kind
Yeah,
of
yeah,
myxoid changes.
that's a really good thought. So we got possibly some desmoplastic changes. But like, look at all these cells, they're just kind of like, let's go high power. Like, have you guys seen any like, you know, like variation in size and shape?
Well, there's just a mitotic figure that you just walked past.
Oh, I did, sorry, I'm seeing.
Yeah,
like
it's on the
this-
right top. No.
Top right, top. Is it close? That one?
Anaphase.
I don't,
It doesn't matter, move on.
but okay, so there's some lights, okay, so that's not great. There's maybe some necrosis, maybe
Maybe
here.
hypocellular, right?
Yeah,
Come on, you guys have seen soft tissue pathology. You know?
like look at this really dense collagen, lots of calcs. Like, is this screaming like rhabdomyosarcoma at you? Right? Is it? No?
No.
What about leiomyosarcoma? No, it's not. Like, it's more like, what about like SFT? Maybe, what about like a desmoid? Those long sweeping fascicles, right? And then not here so far. It's fibrosing, it's calcifying, right? So that's kind of,
Calcifying, it's fibrous.
like, it's sure sounds like one of the answer choices, right? Like, and you know, like when you see stuff like this, oh, is it a gist, right? Is it a gist? You guys seen gists? Doesn't really look like a gist, right? Leiomyoma, it'd be a weird leiomyoma. So you're looking at like this, oh, IMT. You guys probably seen IMTs before, like they're really inflamed, they're really like dense with inflammation. Not really. So just without knowing anything about this tumor or ever seen this before, you could be like, this sounds about right. But so you you just pick that and you move on. And you'd be right. That's the answer. So let's kind of just talk about some of these. So this is apparently a rare tumor. It's grossly, it's kind of hard. It's fibrous and calcifying, and this is from this PMID right here. And then histologically, from that paper, they're like, there's pseumomatous dystrophic calcifications, there's dense, kind of hyalinized collagen deposition. There could be some plasma cell lymphocytic inflammation, which there was. It's just not as much, and there could be some more like kind of more background lymphoid follicle kind of aggregation. So with this one, that paper said, like, you know, your differential is, you know, these, and you could rule it out by getting like STAT6 USB6 fusion, which will, if it's negative, will generally rule this out. Fibromatosis, you get a beta-catenin. IMT, you could send for ALK, but there are ALK negative IMTs as well, so that's also just something to know about. Just you get a CD117 and DOG1, and all of these, if these are all negative, you know, you're ruling these diagnoses out. And leiomyoma is possible, but like it just doesn't look like that. So that leaves you with a calcifying fibrous tumor, which sounds exactly what it should be on histology. it could be related to IgG4 disease, but people don't.
Nah.
Right, yeah, okay. So it's not related to IgG4 disease. And then the stains that normally you would do for this is like CD34, but like a lot of things stain with CD34, so it's not super specific. Vimentin, again, is not specific. And factor 13A, we didn't do this. I think when we signed out this case, we just ruled out most of these, and then we showed it around the department, and everybody seemed to agree that it's probably a calcifying fibrous tumor. Oh yeah, this is how it was finally signed out. It's kind of big. And yeah, we did a keratin, and we ruled out GIST, and CD34 here was negative, and beta-catenin was negative. So we ruled out a desmoid.
Okay. Some rheumatoid calcifications are so characteristic. You know, I've almost never seen them in any other entity. I've seen calcifications occasionally with leiomyoma, so they're big blotchy calcifications. These are sort of samoma-like bodies. They're very, very characteristic. So if you ever see them, that's probably what you're dealing with.
Jeff, you said that you were both for a frozen section or something?
What, say, I can't hear, what? Say again.
There was a frozen section for
Yeah.
this, right? How did they sign it out on the frozen section?
On the frozen, so okay, this is what generally we do at our institution. I don't know if it's like a trend or anything, but whenever we get a spindle cell lesion on a frozen, we just say low-grade spindle cell neoplasm, defer to permanent, or high-grade spindle cell neoplasm, defer to permanent. We don't.
That's not what we do here. No, I'm just kidding.
We don't,
I like
we
it, I
don't,
like
we
it.
just, we got in a lot of trouble with some cases, because some people would like call it something. And sometimes they'd be right, but sometimes they'll be wrong, because spindle cell, you need molecular, you need IHC, and then everything looks like everything, and so I think they just made that, like, just call it defer to permanence, and the surgeons are okay with that. They know that we can't go without, we can only go so far.
Is this in any way linked to those peritoneal loose bodies that you sometimes see at autopsy? There was
Oh, like
kind of-
those rice bodies? No,
No.
this is different. This is actually a neoplasm, right?
Right.
But often you'll find it incidentally, if you go looking in autopsies very carefully, you might find them. So it's not that uncommon, but to form masses like this would be very uncommon.
Yeah, we didn't expect it. It was pretty weird for us. So this is a gentleman with HIV, and they got an esophagus biopsy. If you look at the answers, you're like, okay, is there going to be eosinophils? Is there going to be herpes, adeno, CMV, or fungi? So knowing this, you kind of already know what you're hunting for. And like even at this low power, you could see like it's pretty blue already. So you're suspicious that it's pretty inflamed. I won't spend too much time on this case, but if you were to zoom in, like in this area, you kind of zoom around a little bit, and then you zoom around a little more, and then like, whoa, right? Like, look at those cells. What are these? Right? What do you guys think for this case? Like, what is that?
Can you go a little higher?
Yeah. Look at that. Look at that nice like margination. You got that nucleolus hanging out there. I can't see one, but I have a picture of it that I saved on the PowerPoint, which is super duper characteristic. But like you're seeing these really big cells. And then like, okay, oh my God. Like that's the one I was looking for. And then you know, textbooks will be like, oh, you know, CMV is at the bottom of the ulcer, and then HSV is on the sides of the ulcer, or vice versa. Like, I don't know, on the boards, they didn't really test that because it's so hard to tell where the biopsy's from sometimes, but I don't know, just there's a way to differentiate it based on that. Like, oh my God, look at that. Like, so when you see those cells, you should be thinking viral, hopefully. You could also think fungal, so I think we've got a GMS on this as well. But this is one of those diagnoses that you find them, and then you see this and kind of move on. For adenovirus, you're looking more like big nuclei and smudgy, very smudgy. And then for herpes, you're looking for like either multinucleation, molding, or marginalization. They love testing marginalization because that's the hardest one to see, and they'll try to trick you with that. But it's just when you see marginalization, please pick that. Okay, so this one, I had to include a picture of an owl. It's very, very characteristic. You see, here's his eye or her eye, I don't know. And then here you see this really very prominent nucleolus. So this is like one of those, kind of muscle memory diagnoses. You see this and you hopefully move on.
Sorry,
Oh, yeah, So the differential here is CMV, HSV, adeno, and you can probably sign this out without AHC, but I get AHC, I don't know. And then we signed this one out as squamous mucosa, lots of ulceration, granulation tissue, and immunostains for CMV was positive. So we just went with that. So this one's.
But the epithelium doesn't look strictly, reactive. I mean, there is tons of atypia.
Yeah.
I mean, is there something else going on there? I mean, HIV patients do get squamous cell carcinoma of the esophagus.
That's a really good point. We thought about that because it is pretty typical. It could be like a fully differentiated carcinoma. Maybe throwing a keratin on here would be a good idea, but
granulation tissue in the GI tract can look really bad.
Yeah.
This looks really, really bad, but seems to be consistent with granulation tissue. Yeah, often, we'll throw a keratin stain just to make sure, but my guess is it's probably just reactive. What's interesting is that I don't see very much cytoplasmic inclusions. We're just seeing nuclear inclusions. Generally, you always see some cytoplasmic, those reddish little dots. The other thing it brought to mind is Joel Greenson, who's a very well-known GI pathologist from Ann Arbor, used to say that if you see a lot of histiocytes, you should think of CMV in the esophagus. Yeah, not very characteristic. You don't happen to have the immunostain, do you?
No. Okay. We got 15 minutes in the next case. So this case is not.
I just had a quick, for skin, as far as CMV versus herpes we usually always see in the epithelium, so the epidermis or the follicular epithelium, and CMV would usually see in vascular endothelial cells. So in the dermis. So is it the same in esophagus as far as which
it's the same.
tissue? Yeah.
So if you don't get squamous epithelium, you can't comment on herpes.
Yeah.
The other thing I'd say is, unless I actually see inclusions, with CMV is a different matter, right? The immunostains will show stuff that can't see on the H&E. But with herpes, unless I see it on the H&E, I've almost never seen it on the immuno. Right? It's always
Do you find
there.
that in other institutions? Because I find here I have.
Really? Oh my God,
Do
okay.
you know from outside places if it's better? Because I agree, usually I'll just see it on H&E.
Yeah.
And if I don't, the stains are negative.
Maybe it's different in the skin and the esophagus. I mean, I've never randomly ordered an HSV and found it positive. I've always seen it when it's there.
No, but we've had some cases that we know are positive on H&E, and then just like to tell VZV versus HSV, we do both mpoxes and both be negative. But we know it's.
Do you report the immunostains?
On something like that, I probably might not. Or might make a note about.
I'll move on to case 5. So this case was really, really cool. It's not something that like I'm trying to trick you guys here. It was like a relatively young adult, dysphagia stricture, got an EGD, then got a biopsy. And when I was looking at this, this was like during my GI biopsy elective. And I was like kind of looking at this and I'm like, okay, squamous epithelium looks good. Wait a minute. Right? Like, wait a minute, that ain't supposed to be here. So like, I'm like, wow, there's a lot of intestinal metaplasia, or am I in the colon? And then I'm like, okay, this makes no sense. This makes so that's what the reason I included this is not to trick you guys. It's like when you get cases like this, it's like, okay, you gotta take a look at your rec and see if there's a specimen mix-up.
Colonic interposition.
Yeah. Yeah, so I looked at the rec and the EGD was like congested, texture, mucosa, change, so not really helpful. And then, I think this guy, it's not playing. That's okay. He's supposed to like look up and do a double take. So I looked at the history for this case, and it was a gentleman from who grew up in Mexico. He had like a lot of vomiting, and then he was at the hospital for an extended period of time. Then he had issue with like swallowing solid food. And then he underwent an endoscopy, said he had like a hiatal hernia, really bad acid damage to his esophagus, and he got 1/3 of his esophagus replaced with his colon. I didn't know this was possible. I was like, this is crazy. There's no way this is real. So then, this is how we signed out this case. There's candida there, but it was also some squamous mucosa with segments of colonic epithelium. And then we kind of mentioned the patient's history. We did the workup for fungus, and there was some candida. But really, the goal was what I want to talk to you about is, yeah, there you go. He does it now. That's what it looks like. So in here, the portion of esophagus can be removed, and then the colon is used as a graft, and it's considered to be a good esophageal substitute. Yep. And the indications for the surgery is like tumors and some benign diseases. The article I saw said epidermis bullosa can cause sloughing. Okay, but this is what they do. This is what they do. This is wild to me. They would take a part of your stomach and esophagus. They would cut it off here. They would cut a part of like your colon over here, right, at the ileocecal valve, and then they would transpose it to the top, like, oh, there we go, right over here, and that's normal. That's a thing. There you go. Like, I didn't know that it's possible, but it's possible.
What would you call this guy's burping?
It's kind of it's unfortunate. Like,
Hey, okay, I have a question for the resident. So if you see columnar epithelium in the upper third of the esophagus, which is not colon, what do you call that? Not Barrett's, it's not Barrett's. It's called a gastric inlet patch. So you can have a patch of colonic mucosa, columnar mucosa in the upper third of the esophagus. It looks like gastric mucosa. Now you can have gastric mucosa in the rectum. What do you call that? That's called the outlet patch. Seriously, it's called outlet patch. So you have an inlet patch and an outlet patch. So you can have various kinds of mucosa distributed through the GI tract, other than metaplastic events. So there's an inlet and an outlet patch.
Cool. Okay, so this case, case 6, and this is again kind of more hopefully straightforward case. And I try to give you guys, a lot of info with the history as well, because with that kind of history and this kind of findings, you should be thinking about a certain entity. So even from this low power, I'm not gonna. Well, okay, I guess I'll zoom around a little bit. So this is a patient with alcohol abuse. They got liver cirrhosis, and they have stomach polyps, and they had an EGD. So this is, just even from this power, like what's super striking to you guys here, right?
Eosinophilic.
Yeah, very, very kind of eosinophilic. What about these right here?
Like dilated vessels, probably?
Yeah, and like what do people with cirrhosis tend to get in their esophageal tract? Portal hypertension, varices. So they this is what a portal hypertension gastropathy can look like. And then, you have really dilated mucosal vasculature as well as submucosal. Yeah. So there's fibrin thrombi here as well. There's fibrin thrombi. When you're seeing thrombi though, that puts GAVE higher on the differential. But then you have to like clinically correlate and look at the EGD, because in gastroantral vascular ectasia, you have more of like the rugated stomach where it kind of looks like a watermelon. Apparently, like, apparently, like, I don't know if that's true, but the books say it's true, so it must be true. So, again, you kind of see like, really the take-home picture here is really large dilated vasculature. And a patient has portal hypertension, cirrhosis, so you're thinking about one of two things. You're thinking about portal hypertensive gastropathy, or you're thinking about gastric antrovascular ectasia. And that's where we were as well with this case. And that's kind of what I put you guys here. The polyps were just a distractor. Very briefly, stomach anatomy, you have cardia, fundus and body, and you have the pylorus. Histology in the corpus and fundic mucosa, you should see some parietal and chief cells. In the antral mucosa, you kind of have more mucin secreting glands. So we were more in this part of the biopsy. The histology features from this case, there's a lot of dilated capillaries. We saw some fibrin thrombi. EGD pictures, when we looked at it, didn't really mention raised mucosal stripes, which is like the food-related term for the watermelon stomach. And then our differential was here. Very briefly, this is all from Kurt's notes, fundic gland polyps. They look more like polypoid. They have parietal cells over here. Hyperplastic polyps, they're more hyperplastic. The close-up pictures are a little better for this because in parietal polyp, fundic gland polyps, you kind of see, because they're in the fundus, you're seeing more of like parietal cells, dilatation. And then in hyperplastic polyps, you're seeing just more like growth-related changes, like more glands. So the differential here, this is the kind of the slide that's more interesting. We either have PGH or Gave. I don't know if it's Gave or Gave. I don't know how to pronounce it right. It's Gave. You should see like this hypothetical watermelon stomach that's only been reported in case reports. I don't know. It's just, it exists. There should be no fibrin thrombi, but here you're more likely to see thrombi. But we had thrombi as well. The thing is, both of these can coexist. But when you look at the clinical situation, PGH occurs more likely in patients with cirrhosis, and Gave occurs more likely in patients with autoimmune disease, but it can also occur in cirrhosis. So we favored that it was a portal hypertensive gastropathy, and the biopsy was done mostly to rule out malignancy. No therapy for gastric polyps, and then because the patient was drinking, but then the patient wasn't drinking since June 2021. So yeah, the takeaway from this case, we favored PGH more on the clinical. And here's a picture of portal hypertensive gastropathy, kind of what we saw, very large dilated capillaries, and then kind of these dilated appearance of portal kind of hypertensive changes. And then this is gastric antrovascular ectasia. Similar, you have these vessels, they're ectatic, they're not supposed to be there, and fibrin thrombi. If you were to see this on the boards, they would probably just be like, fibrin thrombi, what is it? And you pick Gave. But if there's no fibrin thrombi, then you pick PGH. Because they're not gonna try to torture you like that. It's just too hard. Oh yeah, so we talked about this. And then this was how we signed it out. We did a descriptive as a header, and then we said that in the context of drinking and liver disease, we think this is portal hypertensive gastropathy. Okay, we got two cases left. I'll go through these kind of quickly, but they're really cool. So okay, this is a patient, not that much history, not feeling well, heterogeneous. PET scan of the liver. Okay, what do you guys see?
Sinusoids are packed with something.
Yeah. What do you think?
Finally.
Yeah. What do you guys think? Anyone?
Sure to him.
Okay. So yeah, this is like sent to heme. This was like, okay, we saw it. Goodbye. Consult to heme.
It does bring up the differential. What other than heme can go down the sinusoids like that, right? I mean, angiosarcomas can do that. epithelial hemangioendothelioma can occasionally do that. I've seen metastatic carcinomas traveling up and down the sinusoids like that.
Wow.
Just trying to think of anything else, but heme things are most likely to spread in that sinusoidal pattern.
Yeah, this was like, yeah, very unexpected. So for this case, this is a bonus case. We had a history here. They were worried for HLH, so they biopsied, but this was signed out as large B-cell lymphoma with intravascular large B-cell lymphoma. We did the germinal center, non-germinal center, and overexpression of BCL, so it's a non-double hitter. And then briefly, here's it got all the workup, and then you could see that CD10 was negative, so that puts it here. And then BCL6 was weakly positive, so that puts it here. And then MUM1 was positive, so that puts it here. So this will be on your board. So you got to know this. They will test you on this. This is guaranteed. And then the double hitter, it was only positive for BCL. So I wanted to show this case. That was intravascular large B-cell lymphoma. And then another case right here. Again, also super cool. Not good for the patient, but
Anything we think is cool is not good for the patient.
Yeah. To check this out, like again, kind of similar story, but what are these? Yeah. And like, what kind of differentials do you want to think about with those?
Invasive lobular carcinoma.
Yeah, so signet ring carcinoma, like fully differentiated adeno from the stomach, lobular, but it wasn't those.
Yeah.
It wasn't those. So this was, you know, the patient's clinical history helped us out a lot here, but you look at these signet ring. Plasma cell neoplasm, yeah. So here, this was just like metastatic melanoma in the.
Wow, it's almost signet ring melanoma, wow.
Yeah, so this, I've never seen this.
If you go back to the H&E, they look
Yeah.
like signet rings. Yeah, they look like signet ring melanoma, wow.
Yeah, this was very like unique case for us.
That's pretty cool. It just goes to show melanoma can look like anything.
Exactly.
Yeah, and then like could be a plasma cell neoplasm too. I don't know.
Yeah, that's a perfect example of a signet ring.
Cool. Okay, well, thank you, everybody.
Nice cases, thank you.
Thank you.
Hi.